So good afternoon, everyone. First of all, I would like to thank all the faculty today to join us. And before that, we start our webinar, I would like to salute our soldiers. And I would like to be, reminded, and I would like to remind everyone that, the sacrifice the soldiers have given for our security. So maybe a 30-minute pause before we start. Okay, Dishank, we can go on to the next slide. So our program director for today is Dr. Prashant Mehta. I just received a call from him. His patient is bad in BMT, so he has to attend. So I will take the proceedings from here and I will introduce our program moderator. So today we have Dr. Rakesh Reddy, sir, who's a senior consultant, head BMT physician and regional coordinator of medical and hemato-oncology at Apollo Center, Visakhapatnam. So I welcome you, sir, and the proceedings over to you. Thank you.
Thank you, Karan. Thank you so much for having us all here. And I'm more than happy that you have made the first slide as a tribute to our brave soldiers who made this possible. Like all of us getting together, life being normal is because of their continued sacrifices. Salute to them. And thank you for this unique program as well. I've seen the way the program is being created, and haven't had the opportunity to attend it before, but I'm sure a lot of young medical and hemato-oncologists that are budding up across the country are being benefited by this endeavor. So grateful to the E-Gurukul series of Icon and Amrita for that as well. And we are blessed by presence of very good faculty to guide us through. And the mentor for today's program or activity is my good friend, Dr. Stalin Chowdary Bala. We are from the same city, at least the present where we are working. He is chief medical oncologist and hemato-oncologist and BMT physician at Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam. Welcome, Stalin. Next slide. The speaker is Dr. Saswata Saha. He is consultant clinical hematology and cellular therapies at Tata Medical Center, Kolkata. Welcome, Dr. Saswat. And for the next slide,
so we can have we can have him as a speaker. Then we can take the rest of the session after sir is done.
Sure. Thank you.
All right. Thank you. Thank you, sir.
I hope I am audible and my slides are visible.
Yes, very much so.
Yeah. So good afternoon, everyone. So first of all, I would like to thank Icon Amrita E-Gurukul for giving me this opportunity to discuss regarding this topic of drugs which are used in HSCT. So if we look the drugs that are mainly covered in HSCT are the drugs predominantly which are used in conditioning, and second part we will discuss regarding the drugs which are used in GVHD prevention or treatment. So if we start with the first part, the drugs which are used in conditioning, the purpose of using a conditioning regimen prior to stem cell transplant are two. First is the eradicating and the tumor and creating a space for the stem cell graft, and second is to replace the patient's immune system with a new donor immune system and to facilitate engraftment. Hence, the drugs used in conditioning regimens are a combination of myelosuppressants which act predominantly by inducing DNA damage and inhibiting.
But sir, sorry to interrupt you. Sir, could you turn your volume a little bit up? You're not very audible.
Now is it clear?
Yes, yes, sir. Excellent.
Okay. So, since the drugs used in conditioning regimen are combinations of myelosuppressants which act predominantly by inducing DNA damage and inhibiting DNA repair, and another category of drugs which are important are immunosuppressants. They are predominantly the nucleoside analogs. So, if we look at the various conditioning regimens that has been traditionally used, as per the CIBMTR data, the most common regimens used in allogenic, the drugs are fludarabine, cyclophosphamide, busulfan, TBI being used, and eight others at ATG, melphalan, etoposide, and the drugs that are predominantly used are in autologous are melphalan predominantly, followed by etoposide, BCNU, Ara-C, cyclophosphamide, and so on. So, the major group of drugs which are myelosuppressants are belongs to the alkylating agents, and the alkylating agents form the backbone of conditioning regimen. And there are six classes of alkylating agents, which you all know as they are classified as nitrogen mustards, which includes mechlorothamine, cyclophosphamide, ifosfamide, melphalan, and chlorambucil; alkyl sulfonates, which includes busulfan and triosulfan; eth- ethylenamine and methylamine derivatives, which are thiotepa; nitrosourea, which are carmastine, lomastine; triazines, which are dacarbazine, procarbazine, and temozolomide; and platinum compounds, which are cisplatin and carboplatin. The platinum compounds do not traditionally alkylate, but they result in covalent adduct formation. So, if you look at the mechanism of action of alkylating drugs, the alkylating agent, they have the alkylating group which binds with the guanine residue of the DNA, and the alkylated guanine forms cross-linking, which can be intra-strand or inter-strand, and thereby interfere with transcription and replication. So the general principles are that they exert an anti-neoplastic effect at all phases of cell cycle. Drug resistance is not attributable to the MDR gene, and the DNA repair enzyme, that is MGMT, which if methylated, it results in increased responsiveness to alkylating agents. And they are usually myeloablative, and they're predominantly most common side effects are hematological toxicity. So in transplant conditioning, we use this myeloablative properties of alkylating agents. So the first in the class drug are busulfan, which is predominantly used as a, agent in myeloablative conditioning. So busulfan belongs to the general class of bifunctional methane sulfonic acid esters. Its cytotoxic action is through alkylating guanine residues in DNA forming adducts. The most important detoxification step is glutathione S transferase A mediated busulfan conjugation with glutathione to form a tetrahydrothiophenium ion. This step is important for detoxification. If there is depletion of glutathione, then there is increased target toxicity and target tissue toxicity, and the target tissue is sensitive to busulfan. So busulfan is found in two forms. It's can be found as IV or oral forms. So 0.7 to 0.8 milligram per kg of IV busulfan is equivalent to 1 milligram per kg of oral busulfan. And there are some problems that we encounter often while using oral busulfan. They are difficult to administer and required to take a large number of tablets to achieve the desired busulfan systemic exposure, and they are highly emetogenic, highly irritating to the gastric mucosa. They have an unpredictable and erratic bioavailability due to the hepatic fast pass metabolism and variable intestinal absorption, and the incidence of hepatic VOD is more than IV busulfan. So the predominant adverse effects of busulfan are neurotoxicity, with the incidence being 10% in adults and in 7% in children. They higher doses incidence is more common with higher doses, and the risk factors are elderly or third or fourth day of busulfan administration. Uh, and use of prophylactic anti-seizure medications are essential when we are giving busulfan. Second important adverse effect is hepatic VOD, which has been shown that the time interval between the last busulfan dose and the first cyclophosphamide dose, if you are using Bucy 2, is of importance for the development of hepatic VOD. If this interval was more than 24 hours, the risk of hepatic VOD was significantly lower than if it was less than 12 hours. So why this happens, I will come to it later. So, and other risk factors for hepatic VOD are previous hepatic irradiation, other hepatotoxic agents like concomitant use of cyclophosphamide, and those who are carriers of glutathione S transferase is A1B variant, which has 30% reduced clearance of busulfan. So second in the same category is triosulfan. It's a prodrug, water-soluble, bifunctional alkylating agent. It's has a marked immunosuppressive activity and low organ toxicity when compared with high-dose busulfan and cyclophosphamide. So often we see that therapeutic drug monitoring is done for busulfan, which has a narrow myeloablative therapeutic window of 900 to 1500 micromole per minute. And for triosulfan, the plasma concentration of the prodrug are a good representative of the alkylating activity of its epoxy transformers. And correlation between busulfan and triosulfan concentration in plasma and level of specific DNA adducts in the tissue usually correlates with the plasma concentrations. So next drug is cyclophosphamide. So cyclophosphamide is a prodrug and it is converted by hepatic cytochrome P450 mixed function oxidase to both active and inactive metabolites. Cytotoxic activity of cyclophosphamide and its immunomodulatory potentials make it a good component of the pre-transplant regimens. So it is less myelotoxic than melphalan, does not require dose modifications in renal injury, and but the dose limiting toxicity is hemorrhagic cystitis, and maximum tolerated dose uh, as shown as has been seen previously is 200 milligram per kg. So if you look at the cyclophosphamide metabolism, this pathway is important. So cyclophosphamide, they either gets deactivated or activated to 4-hydroxycyclophosphamide, which then tautomerizes to aldophosphamide. This aldophosphamide ultimately gives rise to active alkylating form, which is phosphoramide mustard. So aldophosphamide also undergoes deactivation through aldehyde dehydrogenase and glutathione S transferase. So if we give cyclophosphamide along with this busulfan, they relatively compete with each other for glutathione S transferase, and thereby there's a reduced clearance of busulfan and it leads to increased hepatotoxicity. So next drug that is used are melphalan, which is a bifunctional nitrogen mustard with two alkyl groups. Up to 90% of the drugs are bound to plasma protein. The CSF penetration is poor, and elimination is predominantly by spontaneous hydrolysis plus renal tubular excretion and glomerular filtration. It has a relatively short biological half-life, that is 60 minutes. So the dose limiting toxicities are myelosuppression, GIT, like nausea, vomiting, on diarrhea, and hepatic dysfunction. So other less predominant, less frequently seen adverse events are cardiotoxicity. The biological half-life or short half-life of 60 minutes for melphalan is important because we tend to give melphalan close to the graft infusion. So melphalan has been predominantly the single agent which has been used in multiple myeloma, and various doses has been studied like 200 versus 100. So overall survival was similar, but progression-free survival was better with 200, and median time to progression was also better. 220 milligram was used, and it has been associated with predominantly grade 4 mucositis, delayed engraftment, and incidences of cardiac arrhythmia. So another study compared 200 versus 140 with 8 gray of TBI. So 200 milligram per meter square was associated with faster hematological recovery and reduced duration of hospital stay, less transfusion requirement, and 44-month survival was 65% versus 45% in favor of melphalan 200 milligram, and EFS was similar. So based on all these studies, the majorly used dose of melphalan in multiple myeloma is 200 milligram per meter square. Next drugs are BCNU or carmustine and CCUNU or lomustine. So these are mainly popular for solid malignancies, predominantly for treating the brain tumors owing to its high lipophilicity and capacity to cross the blood-brain barrier. They form part of myeloablative therapy in autologous transplant predominantly, and the major adverse events are myelosuppression, and at high doses, they can cause hepatic VOD, pulmonary fibrosis, renal failure, and secondary leukemia. Next drug is thiotepa, which contains 3-aziridonyl 3-membered ring that can hydrolyze to produce alkylating moieties similar to those of nitrogen mustard. The main important things which are different for thiotepa are its preparation. So after preparation, thiotepa solution should be administered through a 0.22 micron filter, and the major non-hematological toxicities are hepatic toxicities, oral and GI toxicities, CNS toxicities, and cutaneous toxicities. So we need to take special precautions for these cutaneous toxicities, and we need to continuously do sponge bathing for patients in whom we are using thiotepa after thiotepa infusion. So fludarabine, triosulfan, and thiotepa is the main TBI-free regimen which is used in acute lymphoblastic leukemia. So topoisomerase 2 inhibitors, like etoposide, is an active drug. It binds to and stabilizes the topoisomerase 2 cleaved DNA complex. And etoposide prevents religation of the broken DNA strands and catalyzed by the enzyme. And it is used as a part of the conditioning regimen for autologous transplant. And the most common and severe side effects of etoposide include myelosuppression, alopecia, constipation or diarrhea, secondary malignancies, cardiotoxicity, loss of consciousness, and fatigue. So next are the immunosuppressions, which are predominantly the nucleoside analogs. So fludarabine is the predominantly and most commonly used nucleoside analog. It's an analog of deoxyadenosine, and the wide use of fludarabine for LOSCT is attributed to both its immunosuppressive and its anti-tumor activities. The median half-life is approximately 15 hours, which is prolonged. It has a prolonged median half-life, and when used in conditioning regimen, so the significant plasma concentrations have been reported for more than 48 hours after therapeutic infusion. That's why when we use regimens which contains fludarabine, we used to give the stem cell only after around 2 days after the last dose of fludarabine has been given. So the serious adverse events are immuno and myelosuppression, infection, fever and chills, nausea and vomiting. So these are the few commonly used conditioning regimens. So for acute lymphoblastic leukemia, TBI-based regimens are preferred. They can be flu TBI or cyclophosphamide TBI. Chemo conditioning, which are do not include TBI, are flu trio thiotepa or buci or fluci. In AML, few regimens are FluMel, FluTrio, or FluSci. Multiple myeloma, as we already discussed, is melphalan 200 milligram per meter square. For lymphoma, Beam, LES, or LEAM. For neuroblastoma, triosulfal melphalan combination. For germ cell tumor, carboplatin etoposide combination. For thalassemia, usually myeloablative regimens are preferred with buci, flubuci, or flutriothiotepa. For aplastic anemia, usually flu-cy ATG, flu ATG, or BU-cy. Coming to the next part of the discussion, the drugs which are used in GVHD prevention or treatment. So GVHD is the most common and preventable complications post allogenic stem cell transplantation, and the essential components which are required for mounting a GVHD are the immune incompetent host with infusion of a competent donor T cells, and there should be HLA disparity between the host and the donor. So the most common and the most predominantly oldest drug which has been used for GVHD prevention are methotrexate. It's a folate antimetabolite. As a single agent, it has the significant GVHD develops in 70% of the patient. It has found a significant role in the prevention when used in combination with other immunosuppression medications. And the standard GVHD prophylaxis for matched related donor allo stem cell transplantations are methotrexate with calcineurin inhibitor combinations. And methotrexate is given as 15 milligram per meter square on day 1, followed by 10 milligram per meter square on day plus 3, day plus 6, and day plus 11 with leucovorin rescue 24 hours after each dose. The toxicities which we encounter predominantly are delayed engraftment, oral mucositis, and hepatotoxicity. So next in class are calcineurin inhibitors, which are cyclosporin and tacrolimus. They inhibit calcineurin, which prevents in the transcription of nuclear factor of AT and many subsequent cytokines like interleukin 2, TNF alpha, IL-3, IL-4, which decreases the proliferation of lymphocytes. So Storb et al. Showed that the rate of development of acute GVHD grade 2 to grade 4 was 40%, and in HLA match transplant with single agent cyclosporin. The doses of cyclosporin which are used in combinations are 1.5 milligram per kg twice daily, and the dose of tacrolimus which is used is 0.03 milligram per kg per day into 2 to 3 times of the dose for oral dose, as we do not get the IV formulation of tacrolimus, and the dose is divided in 2 divided doses. So if you look at the adverse events of cyclosporin and tacrolimus that have been reported in various studies, so with tacrolimus, the predominant side effects are hypertension, numbness, HUS, TTP, and in the cyclosporin group, there's hypertension, and their abnormal laboratory findings are more common with tacrolimus than with cyclosporin, like impaired renal parameters, hyperkalemia, abnormal glucose tolerance, and hypoglycemia. So incidences of hemodialysis was more common with the use of tacrolimus than with cyclosporin. So which one is better among tacrolimus and cyclosporin? This was a large meta-analysis which compared tacrolimus plus methotrexate versus cyclosporin plus methotrexate. And the conclusion was that TAC plus MTX has a superior effect in the prevention of acute GVHD in patients who received HSCT, and further prolongs the overall survival in patients who received from unrelated donor transplant, whereas cyclosporin plus methotrexate prolongs the OS in patients who received transplant from HLA identical sibling donor. The leukemic relapse and disease-free survival rates were not different between the two regimens, and thus they concluded that tacrolimus plus methotrexate was superior to cyclosporin plus methotrexate, especially for transplants uh, uh, patients with non-malignant disorders, and further studies were required uh, to evaluate the effect of tacrolimus and cyclosporin combined with other immunosuppressions in the, treatment regimens following HSCT. So next drug which is used as is a cyclophosphamide. It's used post-transplant, commonly we know as PTCY. So it is given predominantly on day plus 3 and day plus 4. So it acts on 3 steps. In the initial days, in day plus 3, day plus 4, it results in destruction of alloreactive T cells. In weeks to months, it selectively increases the host regulatory T cell proliferation, and thereby these cells counteracts the effects of remaining alloreactive T cells, and after several months post transplant, it leads to anti host T cell depletion by intrathymic dendritic cells. So, why this happens is that the aldehyde dehydrogenase, which is required for the inactivation of cyclophosphamide, as we saw previously, is absent in the alloreactive T cells, whereas they are present in the regulatory T cells and stem cells. So the aldophosphamide gets inactivated in the stem cells and uh, regulatory T cells, and they are spared. But the alloreactive T cells, they do not have the aldehyde dehydrogenase, and they are usually destroyed by cyclophosphamide and its active congeners. So, if you look at the landmark study by Leo Luznik, so it included 68 patients with high-risk hematological malignancies which lacked matched sibling donor. They utilized non-myeloablative conditioning and bone marrow grafts, where cyclophosphamide 50 milligram per kg per day was used in one group. It was used on single day, day plus 3, and the other it was used on day plus 3 and day plus 4. So the cumulative incidence of relapse was 51%, which was relatively high. The EFS at 1 year and 2 years was 34% and 26%, and overall survival at 1 year and 2 year was 46% and 36%. So the incidences of grade 3 and grade 4 GVHD was only 6% with the use of PTCY, and the extensive chronic GVHD was more in patients who received 1 day of cyclophosphamide when compared to those who received 2 days of cyclophosphamide. So the standard dosing which we use till now for PTCY is 50 milligram per kg for 2 days on day plus 3 and day plus 4. So next is antithymocyte globulin. It plays an important part in transplants with high risk of graft rejection as well as high risk of GVHD, and it's important part of the conditioning as well as GVHD prophylaxis in mud transplants. And rabbit ATG, which is predominantly used, has two predominant types. One is thymoglobulin, which is produced by immunizing with either human T lymphocytes, or another form is grapholone, which is produced by immunizing with Jarka T lymphoblastoid cell lines. So Locatelli et al. Study showed that 15 milligram per kg of rabbit ATG can lead to better EFS, OS, and can spare life-threatening viral infection when compared with higher doses. Subsequently, Kang et al. Retrospective review showed that the use of thymoglobulin as low as 3.75 milligram per kg for mud and 5 milligram per kg for haplo family donor is also useful. So the most important issues with antithymocyte globulin are delayed immunosuppression and increased viral reactivation. So other drugs which are used as sirolimus, which is an immune suppression that appears to work synergistically with tacrolimus. The dose predominantly uses 6 milligram loading followed by 2 milligram per day. So Cartler et al. Used tacrolimus plus sirolimus as prophylaxis in a phase 2 trial of 30 patients undergoing HLA-matched allotransplant. There was only 10% risk of grade 2 GVHD with no grade 3 or grade 4 GVHD. Unfortunately, there was a 10% risk of hemolytic uremic syndrome. Antin et al. Used tacrolimus, sirolimus plus methotrexate in a phase 2 of 34 patients undergoing MUD or mismatch allotransplant, and there was 26% rate of GVHD. Next drug is mycophenolate mofetil, which is a inosine monophosphate dehydrogenase inhibitor. It's a lymphotoxic. It does not cause mucositis, unlike methotrexate conditioning containing regimens. So cyclosporine plus MMF versus cyclosporine plus methotrexate trial closed predominantly as far less mucositis, and earlier engraftment was seen with cyclosporine plus mycophenolate. So commonly used in regimen in reduced intensity and cord transplant as well as in haplo transplants. And the dose which is used are 15 milligram per kg thrice daily. So next agent is alemtuzumab. It's an anti-CD52 antibody. It depletes host and donor lymphocytes as well as antigen presenting cells. It has been used with success with non-myeloablative transplants, but unfortunately, significant viral infections have occurred with its use. And nowadays, it is used in very few circumstances. So next drug is abatacept. It's a FDA-approved prophylaxis for acute GVHD in combination with CNI and methotrexate for allo transplant from a matched or one allele mismatch unrelated transplant. It binds to the co-stimulatory molecule CD80, CD86 on the antigen presenting cells, thereby blocking interaction with the CD28 of T cells. So the toxicities are serious infection, EVV and CMV reactivation, and the usual dose is 10 milligram per kg with a maximum capping at 1000 milligram as a 60 minutes infusion on the day before transplant, followed by uh, a dose on day 5, 14 and 28 after transplant. So steroids are the most effective agents for treating acute GVHD once it develops, and the standard dose which are used are usually 1 to 2 milligram per kg per day for the treatment of acute GVHD. So Chow et al. Randomized 150 patients receiving HLA matched sibling transplant to either CSM methotrexate or CSM methotrexate methylprednisolone. Only 9% of those receiving the steroids, including regimens, developed grade 2 to grade 4 GVHD versus 23% in the other group. So there was no difference in relapse or disease-free survival between the two groups. However, the subsequent studies do not replicate the data, and it is not used as a standard prophylaxis. Next drug is ruxolitinib. It's a selective JAK1/2 inhibitor. It's a drug of choice for steroid refractory acute and chronic GVHD. So the dose is 10 milligram twice daily, and the overall response rate ranged from 45 to 100% in both acute and chronic GVHD. Complete response rates varied from 9 to 67% and from 0 to 28% in acute GVHD and chronic GVHD respectively. So the treatment-related toxicities were observed in 20% of patients, including cytopenia, liver toxicity, and infections. Another newer agent, relatively newer in the armamentarium, is belumosudil. It's a FDA-approved drug for the treatment of chronic GVHD. It is an inhibitor of Rho-associated coiled coil kinase 2, predominantly named as ROCK2. So if you look at the organ-specific response rate, then the predominant organs which are where the responses are higher at joint fascia, lower GI, upper GI, mouth, and esophagus. And the most common side effects are infection, fatigue, shortness of breath, cough, bleeding, stomach pain, muscle or bone pain, headache, and high blood pressure. So with this, we come to an end of the drugs, and thank you for listening.
Thank you, Dr. Saswat. Karan, shall I go ahead and introduce our
Yes, sir. I mean, you can consolidate if you have any comments for the residents as they go for exams or any practical tips.
Right, right. So I think there are questions as well. When do we take the questions at the end of the discussion?
We'll take it at the end, yes.
That's great. So Dr. Sashwat, he has very lucidly summarized all the drugs that we use, both the chemotherapy as well as non-chemotherapy drugs that we use in conditioning regimen as well as in GVHD prophylaxis, and a bit about GVHD treatment also. So the conditioning regimens, probably one thing that is important for a resident who is getting trained to know is what is the disease that we are treating and what is the intent of that particular conditioning regimen. For some diseases, it is very straightforward, like melphalan, we give multiple myeloma, we give melphalan. But for rest of the diseases, other diseases, be it acute myeloid leukemia, acute lymphoblastic leukemia, chronic myeloid leukemia, aplastic anemia, there are conditioning regimens that are aplenty in terms of options, and what we are choosing depends upon how the comfort level that we have for that particular conditioning regimen in our training or in our clinical use, as well as what is the goal of that particular treatment. So we cannot be treating a 30-year-old AML the same way as a 65-year-old AML, even though both of them we are taking for allogenic transplant. So the difference happens in terms of what is your HSCT comorbid index, what is the toxicities that the patient can tolerate, whether it is a reduced intensity conditioning that we are going to go for, or a myeloablative conditioning, or sometimes a non-myeloablative conditioning is also good enough for certain conditions. Uh, so understanding the concept of conditioning regimen is so nuanced in that way, and probably will be very better served by Dr. Navin Khattry sir's comments. So we are blessed by his presence today. Dr. Navin Khattry is Deputy Director and Senior Medical Oncologist at ACTREC Tata Memorial Center, Mumbai. And we have the examinee today also. Next slide, please. Dr. Amol Sitaram Rathod. Dr. Amol is DRNB third year resident at PD Hinduja Hospital, Mumbai. So I think if they take on the session further, and probably we can have a consolidated discussion at the end of it. There are certain very interesting questions that are coming up in the chat box as well. And I myself have a few questions, and then when we can have an freewheeling discussion at the end of it.
Naveen sir, over to you. Dishank, can we have the slides, please?
Good afternoon. First of all, Shashwat, it was an excellent presentation. Transplant is all about the conditioning regimen that you use to a large extent. And whether it's allo or auto transplant, if we have knowledge of pharmacology, then you are best served in treating your patients. If your knowledge of pharmacology is not good, then you may be able to treat patients, but there are things that can go wrong, and then there will be problems. So, Karan, just wanted to find out. So, since this is the first time that I'm in this Gurukul meeting,
Yes, sir.
so Amol is the examinee,
Yes,
and
sir.
we ask him questions. Is that the way it is?
Yes, sir. So we have a set of some outlined questions for you. So you can go through those questions, and as well as questions you find which is relevant for a trainee.
Okay. So maybe we'll begin with something more basic. Um, Amol, why do we
Yes,
use
sir.
alkylating agents in conditioning regimens?
Sir, first we want to wipe out the disease, as well as we want to create the space for the allograft or autograft to take the place of the wiped out marrow.
So, that is the function of the conditioning regimen. The question was, why do we use alkylating agents? Why don't we use topoisomerase 1 inhibitor? Why don't we use antimetabolites?
Sir,
Why don't we use taxanes? Why do we use alkylating agents?
So because the myeloablative potential of the alkylating agents is more.
But if you use taxane at high doses, maybe that will also lead to myeloablation. So, the answer lies in the dose response curve. So when you have alkylating agents, you keep on increasing the dose of the alkylating agent, the cytotoxicity continues to increase, and the plateau occur at a very high dose level. When you use other antineoplastic drugs, the dose response curve is not so steep. it shoulders on very early. What it means is, suppose if you increase, suppose melphalan, if used for myeloma in conventional doses, there was a time where melphalan was used, oral melphalan was used as part of standard therapy. This is some 25, 30 years back. And the dose of melphalan was something like 4 to 8 milligram. When you increase it by tenfold, you are able to increase the cytotoxicity with the same sort of directional proportion. That means as you increase the dose, the cytotoxicity increase till you reach a dose-limiting toxicity. However, suppose you used paclitaxel, then what would happen? After some time, there is a plateau. And that plateau is that even after, if you suppose increase it after a certain dose, it will not further increase cytotoxicity. And at that level, what will happen is only your toxicity will increase, but your cytotoxicity will not increase. And what you need are drugs which leads to good cytotoxicity for malignant disease. I'm talking about malignant diseases because that is where you need to have a drug which can be cytotoxic to malignant cells. So for that reason, you use alkylating agents, because as you increase the dose from standard dose by 8 to 10-fold, you're able to kill more malignant cells till you reach a dose-limiting toxicity. Whereas in other other drugs, you are not able to achieve that. And that's the reason why the alkylating agents are used so commonly in transplant, right?
Sir, with your permission, may I share the dose response curve for alkylators?
Of course, you have that?
Yes, sir. Yes. Uh, yes, sir.
You can just make it a right. So, as you increase the dose, then what will happen is that the cytotoxicity will increase until you reach a dose-limiting toxicity. And the shoulder will not happen at an earlier dose. Now, when you look at other agents, this does not happen. And that is why the dose-limiting toxicity happens a bit early in other group of drugs. So then the next question is, what is the difference between the conditioning regimen that you need in benign diseases versus malignant diseases for allogenic transplant?
So for malignant disease, we need graft versus leukemic effect. And for non-malignant disease, we don't need a graft versus leukemia effect. So less myeloablative regimen can be given for benign disease.
Excellent. So what happens is, in benign diseases, you need a lot of immune suppressive drugs, because what you need is immune suppression so that the donor cells engraft. In malignant diseases, you need higher doses of chemotherapy because you want to kill the malignant cells, even if the patient is in remission. Because patient in remission, how many malignant cells are still there if a patient is in remission? Amol? So when you say that the patient is in remission, how many malignant cells are still there? Just a guess.
I don't know.
So, when we say that a patient is in remission, and I'm not talking of MRD, I'm just talking of, morphologically less than 5% blast or a PET scan showing remission, you still have more than 10 to the power 6 to 10 to the power 8 to 10 to the power 9 malignant cells. So, if you want to get to a level below 10 to the power 6 or anything less than that, then obviously you need to hit them hard with higher doses of therapy. And that's why it's important to hit malignant diseases with more intensive chemotherapy. However, everything in benign disease does not mean gentle chemotherapy. What are the diseases and benign diseases in which you still need intensive therapy?
Benign diseases with intensive therapy.
So in aplastic anemia, do you need very intensive conditioning?
Yes, sir. We need that intensive conditioning regimen and
No. So
like
do you
in
need
aplastic.
myelosuppression in aplastic anemia or you need lymphoablation in aplastic anemia? There's hardly anything in the marrow, right? There's nothing in the marrow.
Nothing
So
in the
you
marrow.
really don't need myeloablation. You need lymphoablation. That means immune suppress the host so that the host does not reject. But what about thalassemia? Do you need myeloablation, lymphoablation, or both?
So both.
Yes. And why?
Marrow is still functional, sir. We want to.
Yes. So marrow is cellular, marrow is hypercellular. So you need to destroy that marrow. And the reason you need to destroy that marrow is to create a space there so that the new cells can come. And then you need to immunoablate so that there is less chances of rejection. So you need a good immunoablation and you also need a good myeloablation. But in aplastic anemia is different. But in malignancy, you need both. You need
Yes,
good chemotherapy or radiation to destroy the malignant cells. And of course, you need immunoablation to ensure that there is no rejection, right? So that's the principle of allogenic transplant, to destroy the residual cells which are there to destroy the cells in the marrow, create space, kill the tumor if it's a malignant disease, and then ensure that there is engraftment by lymphoablation. What is the principle in autologous transplant? What are you looking at as far as chemotherapy is concerned in autologous transplant?
So in autologous transplant, coming to conditioning regimen, there is no graft versus host disease, and we use beam protocol for conditioning.
So in autologous transplant, you are only dependent on the drug's ability to kill the tumor cells.
Tumor cells.
Right? In malignant diseases, right? So the higher the dose you give, perhaps the better. But after some time, there'll be a plateau. You can keep on increasing the dose after that. It will not lead to more cytotoxicity, but it will lead to more toxicity to the patient. Right? So that is the important thing to understand in autologous transplant. So you use drugs which, even in standard doses, have been shown to be effective in a particular tumor. And that's what's important. And that is where the alkylating agents trump over any other group of drugs, because you are able to increase the dose and the dose limiting toxicity happens a bit later. So, these are the two basic principles. Where do you use autotransplant in non-malignant diseases?
In non-malignant autologous aplastic.
I think these were questions which possibly were not there for you to answer. Saswata had given me a list of questions, and Saswata, I thought it's best to start with the basics. If your basics are correct, then the rest is easy. So, in which diseases, non-malignant diseases, does autotransplant work? you're working in a center which is known
Plus,
for that group of diseases. Autoimmune disorders. Hinduja is famous for autoimmune diseases and treatments. Yeah. You've got some very fantastic physicians who look after autoimmune disorders in Hinduja. So the autoimmune disorders are a group of diseases in which autotransplant is used. Can you mention one or two of them?
diseases.
So multiple sclerosis is a classic example. And autotransplant also done for rheumatoid arthritis and some scleroderma patients. And how does it act in these diseases? In malignancy, you're killing the tumor. So what are you doing in non-malignant diseases? So you're resetting the thymus. So when the thymus is reset, it will not destroy self. And when it will not destroy self, so there'll be a period which may range from months to years that the disease will remain quiescent and the flare will not happen. So it is used. And where did we get this notion that it can be used? And very simple, elegant observation many, many years back was when patients with multiple myeloma had autoimmune disorder, such as rheumatoid arthritis, and when they underwent autotransplant, so not only did myeloma get controlled, even the rheumatoid arthritis got controlled. And it's from those observations that then, people started using autotransplant in autoimmune disorders. Yeah. So that's the only benign group of diseases where autotransplant is used. But there are many benign diseases in which allotransplant is used. So apart from hemoglobinopathies and aplastic anemia, where else is allotransplant used in benign diseases? So primary immune deficiency disorders, there's a huge list. And
severe combined immunodeficiency.
Yes. And one of the first transplant in the world, I think in 1968, was done in an immune deficiency disorder. And in that, what do you need? Myeloablation or lymphoablation?
Sir, it is deficiency disorder. We just need lymphodepletion. We don't need myeloablation.
You just need to, you may not need too much of lymphoablation also, because anyways, the host T cells are not great, but you really don't need too much of myeloablation in these patients. Yeah. So, this is the way you have to think when you are using conditioning regimens for both allo and auto. Why do we need to know the half-lives of each drug?
Sir, the protocols are made such that, like if we consider melphalan, the half-life is just 60 minutes. So it is to be given very close to a stem cell infusion. And for side effects also, like and also there are washout periods before infusion.
Yeah. So mostly because of that, you need to know the half-life so that after how many days you need to give the infusion. And what is it typically, how many half-lives are required so that one can think that there must, the drugs would have been washed out from the body. How many half-lives?
So 4 to 5 halves.
So mostly 4 to 5 half-lives. And that is why you need to know what's the half-life of each drug. And that helps for you to plan how many days before the infusion you need to plan. Now, if I ask you what is the dose-limiting toxicity of any drug in transplant, which is not a dose-limiting toxicity in transplant.
Sir, I did not get the question, sir. Sorry.
So the question is, suppose if I told you, what is the dose-limiting toxicity of melphalan? What will be the first or the second that
Myelosuppression.
will come to you, man, to your mind?
Myelosuppression, sir.
So in transplant, myelosuppression is not dose-limiting toxicity,
Not dose-limiting.
right? You want the myelosuppression, you are going to give the cells. Myelosuppression is no longer the dose-limiting toxicity. When you're using melphalan in standard doses, in multiple myeloma, no one uses now standard doses in multiple myeloma, then the dose-limiting toxicity could be myelosuppression. In transplant, myelosuppression is not the dose-limiting toxicity. It's the extra myeloid toxicity which is dose-limiting. Okay. So what is the dose-limiting toxicity of busulfan?
Veno-occlusive. That is a black box.
Yes, liver toxicity. What else?
Sir, pulmonary fibrosis.
Yes, lung toxicity. And when does it typically happen?
Sir, it
What?
is usually after the time duration given is 1 year to 10 years, sir.
Yeah, but at what dose does it typically start happening?
Sir, I don't know the exact.
So typically, if you give it for long, so where was busulfan used earlier? In which disease in standard doses? 35 years back.
Sir.
So, it's very interesting to know the history of how drugs develop. That gives you an idea of what could be the side effects. So typically busulfan was used in CML. When imatinib was not there, low dose of busulfan was used in CML. And what happened is when you gave it for long duration, if you gave more than 2 grams over many years, then pulmonary fibrosis became a problem. So that is why busulfan has lung toxicity as one of its problems, liver toxicity as one of its problems, and neurotoxicity. And that is why you give anti-epileptic drugs
Clonazepam.
for that. Yes, so that they don't develop seizures.
Seizure.
And which drug would you use to prevent seizures?
Sir, benzodiazepines are used, sir. Clonazepam 1 mg twice a day to thrice a day.
Why not phenitoin?
Sir, it has an
used to be used.
interaction with busulfan, sir. It increases the toxicity of busulfan.
Does it increase the toxicity of busulfan or does it do something else? How does phenitoin act?
So
It's an enzyme inhibitor or an enzyme inducer?
sir, inducer, sir.
So if it induces the enzyme, the metabolic enzymes, so what will happen to the drugs?
It decreases its activity of busulfan.
Yes. So its efficacy goes down, right? And for that reason, the diazepams, the benzodiazepines are the drugs of choice rather than phenitoin. But when benzodiazepines were not available, phenitoin was used. And how do you typically give it? Suppose you're giving busulfan from today. How will you time the benzodiazepine?
Sir, we have to start 1 to 2 days prior to the busulfan day.
And to 1 to 2 days later, so that the busulfan is washed out, right?
Washed out, sir. Yes. Sir.
What are the other drugs which causes lung toxicity as dose limiting? Among the drugs which Saswata enumerated.
Yes.
So how much time do we have, Karan?
Sir, we have almost an hour, so you can go up till 4.
Okay. So I can grill him for an hour, is it?
You can also do the masterclass which you did with us on the rounds and teach us about the drugs. I mean, that was one of the most, looked after sessions on the day.
So, what was the question? The question of what are the other drugs which causes lung
pulmonary
toxicity?
fibrosis there.
Yes. So I'll give you a choice between melphalan, busulfan, BCNU, lomustine, etoposide. Which drugs cause lung toxicity? It can be more than one.
Busulfan, this mustard one, sir, lomustine, carmustine.
Lomustine and carmustine. Yes.
Carmustine.
Good. So these are the three drugs which are known to cause lung toxicity. So if you have a patient pre-transplant and his lung function shows a corrected DLCO of 65% predicted value and FEV1 being 60% of predicted value, which drugs will you avoid then?
Busulfan I will avoid, but I can give lomustine in a LACE protocol to reduce the further pulmonary deterioration with frequent monitoring.
What about beam for transplant?
So for lymphoma,
so the patient has a DLC of less than 65% predicted value, FEV1 of less than 60%. You will not use busulfan. You will perhaps use lomustine, but what will you do with carmustine? Suppose if you wanted to use beam, will you avoid it or will you give that regimen?
So carmustine is avoided, sir. Lomustine can be given in
Yes.
lean protocol.
So BCNU would be avoided because the propensity for BCNU to cause lung toxicity is much more
Higher,
right? Than
Yes, sir.
lomustine. Lomustine can also cause, but the dose of lomustine which causes lung toxicity is anything more than 10 to 15 milligram per kilo. However, for carmustine, even 300 milligram per meter square can cause lung toxicity, which is the dose which is used for beam, 300 milligram per meter square. So one has to be careful, for that. Now, come to liver toxicities. Which drugs cause liver toxicities from the list of drugs which Shashwat had enumerated?
The busulfan, we know occlusive disease is there. Methotrexate can cause. Then
do you use methotrexate in high doses in transplant?
No. Sorry. Yeah. Later on, so not in the conditioning regimen.
Yeah.
And conditioning regimen, busulfan causes veno-occlusive disease. So we have to monitor abdominal girth twice a day and LFTs. Apart from busulfan, etoposide is also known to cause hepatotoxicity. Sir.
Okay. So the simple answer to this is nearly all drugs cause liver toxicity. Some cause more, some cause less.
Cause less, yes.
Yeah. And those who cause more, the culprits maximum are busulfan, right? Carmustine, thiotepa, okay? Melphalan to some extent, right? What were the other drugs that you mentioned, Shashwat?
Cyclophosphamide.
Cyclophosphamide, yes.
And etoposide.
So, these 5 or 6 drugs are notorious for liver toxicity. Okay. Among the alkylating agents, which have less propensity to cause liver toxicity? Maybe if you put that drugs, Shashwat, That makes it easier. Otherwise, we don't remember. That first slide or second slide of yours, that will be easy for Amol to then choose from them, when it is in front of us.
I will share.
Because, the knowledge of all this is very important when you choose a regimen. Unless, we understand the pharmacokinetics, unless we understand the organ toxicities of each of these drugs, we may cause more harm than benefit. I think it's before that the one which had, yes, this one, yeah. Just keep it there. So does fludarabine cause liver toxicity?
Sir, yes, sir.
Yeah, but maybe less likely.
Less likely.
What is important for fludarabine? What do you need to check if you want to give fludarabine? Liver function or renal function?
Renal function, sir. Renal clearance doses modifications are there for.
Excellent. So 80% of fludarabine is excreted by the kidneys unchanged. So if your GFR is low, you need to modify the dose of fludarabine in renal dysfunction, right? So it's not liver, but it's the kidneys which are important for that. And if you don't modify the dose, what is the problem? Does it lead to renal failure or does it lead to something else? So basically what happens, the kidneys are the organs through which it gets excreted, unchanged. So if the kidneys are impaired, then obviously it's there in the blood at higher levels. So which organ gets damaged if the fludarabine is lurking in the body for so long at that high doses? Brain.
Don't know, sir.
So neurotoxicity is something one has to look for when you have fludarabine being given in any patient who have compromised kidneys. And that's why you have to modify the dose of fludarabine. Cyclophosphamide, what dose limiting toxicity does it have?
Hemorrhagic cystitis.
Is that dose limiting in this day and age? Hemorrhagic cystitis 100% can be prevented by what? From hemorrhagic cystitis of cyclophosphamide. Sorry?
Sir, Mesna, sir.
Excellent. And what does Mesna do? What causes hemorrhagic cystitis in cyclophosphamide?
Sir, the acrolein, causes the, so it, what Mesna does is donates the sulfhydryl group to the acrolein and stabilizes it. And therefore hemorrhagic cystitis is prevented.
Yes, that's why. So, hemorrhagic cystitis does not really happen no matter what dose of endoxan you use. You just have to give commensurate dose of Mesna. So what dose limiting toxicity happens with cyclophosphamide? Liver. It is notorious to cause problems in the liver, right? And that is why when you give busulfan with cyclophosphamide, if there is one organ which is worst hit, that is the liver. And we'll come to that in some time. So you have to be very careful when you give cyclophosphamide. Busulfan we just discussed.
Yes, sir.
What is so good about TBI? I mean, people don't like TBI. If I tell you that TBI is great, what is so good about the TBI? Or there is nothing good about TBI?
I don't know, sir.
So, some drugs are good in myeloablation. Some drugs are good in lymphoablation, right? Is there any drug which has very good myeloablation and lymphoablation, any agent? It's TBI. It causes myeloablation at higher doses, and it causes lymphoablation even in lower doses. Okay, so if you give TBI at a dose which also causes myeloablation, then lymphoablation is taken for granted. And that is why it is a very important agent, even in this day and age. No matter how many times its obituary is written in transplant, because it does this too very well. So in TBI, what is the standard doses of TBI that is used, say in ALL?
Sir, 12.8 to 13.2 gray, like over 4 days. Initial 3 days it is 1.2 gray, thrice a day session, and on 4th day it is 1.2 gray twice a day session.
Right. What do you have to take care of after you cross 8 grays or 7.5 to 8 grays? Which organ do you have to be specially careful with?
Liver.
Anything else? Do you have lung blocks for high doses of TBI? Lung shielding?
Yes, sir.
So the lung is the most important organ after a certain dose of TBI. Okay, so you have to shield the lung. And for that reason, it is important. So that is TBI. Okay, ATG, is it lymphoablative or myeloablative?
Sir, lymphoablative.
Lymphoablative. Does it also depend on what type of ATG?
Sir, rabbit ATG, horse ATG are used. Rabbit ATG is preferred.
Why is rabbit ATG preferred? So there is data that rabbit ATG is immune suppressive, and it's more, it's a better drug to prevent rejection. So that is why in conditioning regimens, it is preferred. And the GVHD rates are also better with rabbit ATG. And for that reason, the rabbit ATG, at least in conditioning regimens, it's preferred. But when you give it for aplastic anemia, then the horse ATG is the preferred ATG as an immune suppressive agent without transplant. Melphalan, we spoke. What's the dose limiting toxicity of etoposide? You can easily say liver, because most of the drugs will cause damage to the liver. But is there anything more specific? The gut. The gut is a problem, and to some extent, even the skin. When you give high doses of etoposide, it also causes skin toxicity. But the gut toxicity is one of those dose-limiting toxicities for etoposide when you use it in high doses. In allogenic transplant, is there any disease where etoposide is used in high doses? It's one of the standard regimens, one of the components of a standard regimen. In ALL. So one of the common regimens used in some parts of the world is TBI with etoposide.
Etoposide.
Yes, and that's one of the standard ALL regimen for transplant. Thiotepam. So what are the dose limiting toxicity of thiotepam? Liver. Liver is always dose limiting for most of the drugs, right? And to some extent, skin and CNS. BCNU we discussed. Do we use RSC in allogenic transplant? So what is RSC? Is it myeloablative, lymphoablative, or both?
RSC is both, sir.
Excellent. Which other is a myeloablative and lymphoablative apart from RSC in that table? Apart from TBI and RSC?
So
There's
fludarabine
one
is
very
both more of
important drug.
lympho.
Sorry?
Sir, I was saying fludarabine is both more of lymphodepletion.
Sure. So apart from TBI and RSC, there's one more drug there in that list, which is both lymphoablative and myeloablative. Even others are, but that's one of the most important drugs. Cyclophosphamide. It's one of the very good lymphoablative drugs. So RSC also is in that league. And again, the toxicity of RSC typically is liver and then CNS,
CNS.
right? Okay. So in this list, I will now come to triosulfan. Is triosulfan a good drug or a bad drug?
This good drugs are better than busulfan. Side effect profile is better than the busulfan.
Yes. So, the liver toxicity is less likely with triosulfan, though of course it can have liver toxicity. The skin toxicity is also there, but maybe to a lesser extent than busulfan. Busulfan is notorious for skin toxicity. And the lung toxicity is also there, but it is less. So wherever you use busulfan, you can replace it with triosulfan if you have organ dysfunction of any of these organs, right? So that's how we use it. Now, when you come to the right side of list, let's look at carboplatin. If you give high doses of carboplatin, what can happen? So where do you use high doses of carboplatin? In which transplant? So I'll give you a hint. It's one of the solid tumor transplant that you use a lot of carboplatin.
Sir, germ cell tumor.
Excellent. Germ cell tumor. Okay. And what do you expect if you give high doses of carboplatin? Don't tell me myeloablation. You want the myeloablation.
Yes, sir, we want to. Sir, renal.
Yes. So at high doses, renal toxicity is something that you have to be careful. Can you name me one or two conditioning regimens used for germ cell tumor?
Sir, I don't know the drugs. Sir, the Tiger trial was there.
So, whatever is used in standard doses, those have been used in high doses. So, ICE has been used both at standard doses and high doses, right? ICE has been used in germ cell tumor, even at standard doses, and it has been used in high doses. Similarly, ifosfamide being replaced by cyclophosphamide has been used, and etoposide carboplatin is one of the commonest regimen which is used. So whatever is used in low doses, multiplied by 10 times, and it has been used in high doses in these diseases. So auto transplant is easy. You're not looking at lymphoablation, you're only looking at cytotoxicity of the malignant cells, and any drug which has a good dose cytotoxicity curve, they can be used. if the malignant cells are sensitive to that drug. Okay. So do you know something about myeloablative, reduced intensity, non-myeloablative regimens?
Yes, yes, sir. The
Can you define them?
myeloablative regimens are the regimens where it requires stem cell infusion for the marrow to recover. It cannot recover without stem cell infusion. Where the non-myeloablative regimens are such that it may not require the infusion of stem cells for recovery.
Excellent. And what is reduced intensity?
So reduced intensity is myeloablative regimen, which are given to reduce the toxicity of the drugs, especially used in elderly where the comorbidity indexes are high and also age is a factor.
But do you need cells for recovery or you don't need stem cells for recovery?
So we need cells for recovery. Only the toxicity we are trying to reduce.
So majority of the time you will require, but suppose if you didn't give the stem cells, suppose the stem cells got destroyed before infusion, or suppose the patient rejected the stem cells in allogenic transplant, what is the chance of recovery in a reduced intensity versus chance of recovery in a myeloablative?
So myeloablative is 0, and here it is around 20 to 30%.
So in reduced intensity, depending on the intensity, it can vary, but in most, it may recover, but it will take more than 30 to 45 to 50 days of recovery. And that's when you have to be very careful. You will have a patient with low counts for a very long time, and to keep a patient alive with such low counts for a long time is a challenge. But if you manage to do it, then after a few weeks, the marrow will recover. Right? So this is the difference between the RIC, myeloablative, and non-myeloablative. Give me an example of a truly non-myeloablative regimen.
Flumel and Bucy at like less half dose or 1/4 dose.
No, truly non-myeloablative. Flumel is not truly non-myeloablative. Flumel veers towards myeloablation. It's quite an intensive regimen. You know, when you use melphalan of 140 milligram per meter square. So tell me a very truly non-myeloablative regimen.
So to, this total body irradiation with cyclophosphamide.
So, Shashwat is there to help you. So this is a truly non-myeloablative regimen. You have fludarabine and 2-grade TBI. If you don't give cells for whatever reason, the marrow will still recover. Right? So that's a classic example of a truly non-myeloablative. The other non-myeloablative regimen is only cyclophosphamide. In which disease only cyclophosphamide is used as a conditioning regimen? Only cyclophosphamide. Aplastic anemia. You could only use cyclophosphamide. Of course, it is not used commonly, but that's another. It's a disease where only cyclophosphamide can be used, or in some of the autoimmune disorders if you do allogenic transplant. No, but that's not commonly done. Right? The other non-myeloablative is ATG with cyclophosphamide, again in aplastic anemia, which is used. So, both are lymphoablative, very less myeloablative. So these are some regimens which are truly non-myeloablative. Then flu-bu with only 2 days of busulfan is truly non-myeloablative. Give me examples of myeloablative regimens, truly myeloablative.
Sir, Busey, Beam, uh,
So in
TBI.
auto transplant, do you want myeloablation or not?
Yes.
Yes. So we will not discuss auto transplant for myeloablation because you want myeloablation. So in allogenic transplant, you know what are truly myeloablative? Is being used in auto transplant or allo transplant or both?
Auto, sir.
It can be used in allo also in lymphomas. Not a very great regimen, but it can be used. So tell me truly myeloablative regimens in allogenic transplant.
Busulfan, TBI.
Okay. What else? What's the classic regimen for myeloablative transplants?
Busey regimen, sir.
Sorry?
Bleomycin cyclophosphamide regimen.
Busulfan cyclophosphamide, Busi, yes. Now you have to tell that Busi for 4 days, with cyclophosphamide. That's a truly myeloablative regimen. What else is truly myeloablative? So Saswata has put this slide now.
Yes.
So Busi, yes. Flu trio.
Thiotipa combination.
Is it truly myeloablative? Not truly myeloablative, veering towards myeloablation. Now you have TBI, site TBI. Is it myeloablative?
Myeloablative, sir.
At what dose of TBI?
So TBI is 12.8 to 13.2.
Anything above 8 grays.
Yes.
Okay. Anything above 8 grays is myeloablative. So it's myeloablative at that level. Okay. With TBI. Right? Now, Flu-Mel, what is it?
Myeloablative, sir.
Veering towards that, but not typically myeloablative. It is one of those reduced toxicity regimen, which causes, to a large extent, myeloablation, but it is not truly the myeloablative. Okay. Similarly with flu trio. Right? Now, there's one question in the chat box that apart from CML, is there any other disease in which Busi is used?
ALL, AML.
Sorry?
Sir, ALL, AML.
So yes, there have been 4 randomized study comparing Cy-TBI with Busi in the late 80s and early 90s. And acute leukemias and CML in both Busi have been used. In non-malignant diseases, it was a common regimen to be used in thalassemia, right? So it's been used, but now more and more centers are doing away with Busi because of its toxicity. And the regimen which now is gaining more favor is fludarabine with busulfan. And fludarabine with busulfan can be 4 days of busulfan or 2 days of busulfan. If it's 2 days of busulfan, it is non-myeloablative. If it is 4 days of busulfan with fludarabine, it's myeloablative. So that's what now the regimens which are being used. It's all to reduce non-marrow toxicities, right? So you have a big basket of reduced intensity, and then you have truly non-myeloablative, and then you have truly myeloablative regimens. Maybe now we can go on to the questions which Shashwat had drafted. Do we have them? So this we discussed. Next. This we discussed.
Alkaline.
So are you better off now, Amol, with those
Yes, sir.
questions? This was discussed. So this is important. How should Bucay be administered to reduce VOD?
The gap between busulfan and cyclophosphamide dosing should be at least more than 24 hours.
Why?
Sir, both can cause VOD, and busulfan needs to get washed out before giving cyclophosphamide.
So does busulfan get washed out within 24 hours? What's the half-life of
60,
busulfan?
16 hours.
What's the half-life of busulfan? If that be the case, then busulfan can be given till day -2. It will go off in 24 hours. Does it go away in 24 hours?
No.
So what is the reason that the busulfan and cyclophosphamide should have maybe a 1-day gap between the two? Something to do with the enzymes? So what happens to glutathione S transferase?
Busulfan is means to neutralize it. Glutathione S transferase is required to convert into
So
active one.
if glutathione transferase is completely used up with busulfan, and if
Then
you give cyclophosphamide just the next day, what will happen?
the toxicity of cyclophosphamide will be more.
Yes, because then there's nothing left to metabolize the
Metabolized
cyclophosphamide. And that is the reason the 24-hour gap is usually used, right? If you reverse the sequence, give cyclophosphamide followed by busulfan, will that help?
But our aim for transplantation will not get proper immunosuppression required.
Why not? You are still giving the cyclophosphamide, you are still giving the busulfan, you are just
Yes,
reversing
but
the
due to
sequence.
due to T half and all,
But that's fine. You plan the busulfan in a way that at least 3 days are left before stem cells. You give a cyclophosphamide from day -8. So -8 -7 gives cyclophosphamide. And then after that, -6, 5, 4, 3 give the busulfan. So, there is some data that if you reverse the sequence, the toxicity is less. The VOD is less. And the reason is that the depletion of glutathione transferase and the glutathione per se is much more when busulfan is given before. And once that gets depleted, then what happens is then the cyclophosphamide toxicity increases. So basically, the VOD is more because of the cyclophosphamide toxicity rather than busulfan, but that does not mean that busulfan does not cause liver toxicity. Both together is a double whammy. Yeah. So either you give a gap between the two or you can reverse the order. Next. Shashwat, next, please. Are the slides moving? Yeah. Okay, so now we come to GVHD, is it?
yes, sir.
Are there any conditioning regimen related questions? There were quite a few.
Sir, I had one question
Yes.
regarding why TBI is not used in myeloid leukemia and why it is used only in lymphoid leukemia.
So, it's not that it is not used in myeloid leukemia. If you look at the studies of 80s and 90s, PBI with cyclophosphamide was used in AML, in CML, and in ALL. Now, why it is still used frequently in ALL is because TBI is a very good agent for sanctuary sites. That is the
Yes, sir.
brain, some other extramedullary areas, the testes, in those areas. It penetrates well. So, in fact, the two most sensitive cells to TBI are what? The testicular cells, the spermatogonias, and the lymphocytes. These are the two most sensitive cells to radiation, to TBI. So for that reason, it's still the preferred agent in ALL. Now for
Yes, sir.
myeloid diseases, you also have chemotherapeutic regimens which are good. Anything with melphalan, anything with busulfan combination, triosulfan combination, they're all good. And typically it does not have extramedullary diseases in which, there are sanctuary sites. So for that reason, non-TBI regimens are more commonly used. The other point about TBI is that the late effects of TBI are a bit more than the late effects of non-TBI regimens. But to tell that TBI is not used in AML or myeloid diseases is incorrect. It is only that
Okay.
the late effects are more, and you don't really have sanctuary sites where TBI may be more effective, and that's the only reason. But if you look at randomized study, there's hardly any study which says that TBI is inferior in myeloid malignancies, right?
Okay.
So it's just a balance of toxicity, and many centers don't have TBI. So, why was TBI? Why did Bucy come? The Bucy got evolved from John Hopkins only for the simple reason that many centers did not have radiation facilities, number one. And number two, the late effects of TBI were already known because TBI was started in 1970s. The Bucy came in 1980s, by George Santers and his group in John Hopkins. And they felt that Bucy will not have the late effects of TBI. But that's not completely true. Bucy also causes, all the non-TBI regimens also cause late effects. But the second tumors of head, neck, cervical region, cervix, those were more with TBI. And that is why TBI fell into disrepute in these diseases. Shashwat, are
Navin
there
sir,
any?
there is
Are
one
there
question,
any?
sir. Navin sir.
Yes,
Sir.
yes, Rakesh.
Regarding PKPD of busulfan, that is something that needs discussion as well. There is a question that
Yes,
has come in the chat box.
yes. What's the question?
Regarding PKPD of busulfan, how to dose busulfan accordingly. So, we don't have availability of,
Therapeutic drug
TDM of
monitoring.
busulfan, TDM of busulfan.
Yes. So, Amol, do you have any idea
sir.
on that?
Sir, oral formulation had erratic absorption. The viability was ranging from 10 to 19. Coming to the IV formulation, its viability is good, but giving dose of mg per meter square had means different individual has different AUC curve. So therapeutic drug monitoring is to be done for IV busulfan, but at levels and all, I'm not aware, sir.
So, yes, so therapeutic drug monitoring in busulfan is important from both ways for its efficacy as well as toxicity. And this perhaps is more relevant in non-malignant diseases because the risk of rejection goes up if you don't achieve therapeutic levels. And while it is true that with oral busulfan, the absorption is erratic, but even in IV busulfan, there are many centers which use it for therapeutic drug monitoring to ensure that there is either less toxicity or to ensure that the risk of rejection is low. And that is why busulfan requires therapeutic drug monitoring. And there are quite a few ways in which it can be done. One of the ways is you look at the AUC after the first few doses, and then after that you increase the dose if the AUC shows less therapeutic levels. So that's the way the busulfan is used. And the triosulfan per se also may require therapeutic level, but one of the advantage of triosulfan is that perhaps so far it is not important to measure the levels of triosulfan. Any other questions in the chat box, Rakesh?
Yes, sir. So there are quite a few which Stalin and myself have answered a few of them. I think majorly the questions that are pending are the GVHT prophylaxis related questions only. Conditioning,
Sure.
there are certain toxicity related. I think you have covered most of them in the discussion that you already had, sir. Sir, one point of TMLI, total marrow lymphoid irradiation versus conventional TBI. How better is, should we be moving towards TMLI, or do you think TBI is the way to still go forward?
So is that question to me or to Amol?
To either of you, sir. But I would
So
definitely
first,
want to.
Amol. So what is TMLI and what is TBI?
So total myelolymphoid. Sir, I'm hearing this for the first time.
You're hearing it for the first time. But if you can only break it into few words, you will get the answer. TBI is total body irradiation.
Total body.
So what does that mean? You irradiate the whole body,
Yes, sir.
right? When you say total marrow lymphoid irradiation, what does that tell you?
Only bone.
So you only irradiate the marrow bearing
Marrow.
areas and the lymphoid areas, right? Okay.
Yes, sir.
So just by breaking it up into pieces, what do you think would be the advantage of doing marrow and lymphoid irradiation rather than total body irradiation?
The TMLI will have less late effects and sparing of major organs.
Yes. So what will happen when you give TBI? If you're giving 13 gray, the whole body is getting 13 gray, right? But when you give TMLI, you can perhaps give more grays, but only the marrow and the lymphoid regions will get that much, not the whole body. And so it is a means to increase the dose of radiation to the areas that require it, sparing the other areas of toxicity, so that finally the outcome is maybe an improvement in efficacy, but certainly less toxicity. And what are the toxicities of TBI which we are worried about early part of transplant? So what happens after TBI in the first 14 days? Esophagitis, mucositis, and this can cause horrendous mucositis. The grade 3, grade 4 mucositis with myeloablative TBI is to the tune of at least 40 to 50% or even more, right? But when you give TMLI, then the dose to those areas become less. And that is why you don't get such significant mucositis, esophagitis. And the other important effect is lung. The toxicity to the lung becomes less. And of course, with TMLI, other organs are also spared of high doses. So basically, that's what it is. Is it more efficacious? It's still not clear whether it's more efficacious or not, but it certainly has less toxicity. Rakesh, any other
Yes, sir.
questions?
I think we have covered most, sir. Let's go forward in the GVHD discussion.
Sure. Okay. So now when we come to GVHD, what is the standard GVHD prophylaxis for the last 40 years?
So the cyclosporin with methotrexate.
Excellent. And can cyclosporin be replaced by any other drug?
Tacrolimus can be used to replace it.
Okay. Is there any difference between cyclosporin methotrexate and tacrolimus methotrexate?
So overall survival is same, sir. Just the GVH, acute GVHD are less with tacrolimus and methotrexate, but it did not transfer to increase in overall survival compared to cyclosporin methotrexate.
So there are
And
three
depends.
large randomized studies comparing cyclosporin methotrexate with tacrolimus methotrexate. I think one is in match unrelated donor and two are in sibling or vice
Siblings.
versa. I can't remember. And in that, what has been shown is that the tacrolimus methotrexate reduces the incidence of grade 2 to grade 4 GVHD to a larger extent, but the overall survival was not different. So half of the world uses cyclosporin methotrexate, half of the world uses tacrolimus methotrexate.
Tacrolimus. European countries mostly use tacrolimus with methotrexate.
No, so the European countries usually use cyclosporin methotrexate. The North American countries use tacrolimus methotrexate, But if you look at in a country like ours, is it better to prevent GVHD, decrease incidence, or to treat GVHD? Is it easier to, what is easier? Decreasing the incidence of GVHD, preventing or to treat?
To prevent, sir.
Right. So, why the overall survival was not different in those trials is because those who developed GVHD, they were treated with GVHD drugs, those which act against GVHD. So the patients survived, but then patients developed more GVHD in the cyclosporin methotrexate arm, and that did not affect the overall survival. It only affected the event-free survival of developing GVHD. However, in our country, perhaps preventing GVHD is very important because, there are a lot of infections which happen when there is far more immune suppression to treat GVHD. Now, what is the disadvantage of tacrolimus methotrexate?
So renal issues.
Yes. So the renal toxicities are more and hypomagnesemia is much more. So, a lot of patients require IV magnesium replacement and a lot of hydration to decrease renal toxicity. And what's the disadvantage of cyclosporin methotrexate?
Requires drug monitoring.
Even tacrolimus requires. Both of them require. So the therapeutic window of tacrolimus is more, or the therapeutic window of cyclosporin is more. Now that you've said drug monitoring, so let's even discuss this. What do you understand by therapeutic window?
So the window between the efficacy is optimal and without side
So when you
effects, increased side effects.
So when you say that therapeutic window for tacrolimus is 5 to 15, and the therapeutic window of cyclosporin is 150 to 250, which is a safer drug?
Cyclosporin, sir.
It has a long window. So the toxicity is much less because you have a broad range, which is the normal level. that you want to achieve, right? But in tacrolimus, that it's very narrow, 5 to 15. So if you increase the dose disproportionately, you will have severe toxicities, right? So that way cyclosporine is a safer drug than tacrolimus. The only problem with cyclosporine is it causes more hypertension and more vascular effects, like migraine effects, hypertension. So those are more with cyclosporine. Otherwise, the two of them are nearly equal as far as the overall survival is concerned. So what GVHD prophylaxis has challenged the standard cyclosporine methotrexate in the last 5 to 10 years, maybe last 5 years?
Yes, post-transplant cyclophosphamide, sir.
Yes. And where did it first develop? In which type of transplant?
Haploidentical, sir.
And what is the principle of using PTCY?
The principle is, sir, post-transplant the alloreact, whatever GVL or GVHD is there, that is due to the alloreactive T cells. So cyclophosphamide depletes the alloreactive T cells and spares the stem cells because aldehyde dehydrogenase enzyme is there in stem cells and also in T regulatory cells, but it is not there in alloreactive T cells. Therefore, it selectively eliminates alloreactive T cells.
Excellent. So that is the reason. And that is why not only has it found to be effective in haplo, but more and more centers use PTCY in unrelated and related transplant. What's the disadvantage of cyclophosphamide?
We are giving in higher dose cyclophosphamide here.
So it can increase toxicity. It can increase toxicity to the liver, right?
Yes, sir.
It can cause hemorrhagic cystitis if you have not given mesna, right?
Yes. So, sir,
yes.
So the ideal dose given is 50 mg per kg for 2 days, but in view of this increased toxicity, some like new trials are going on where they are trying to see the efficacy at 40 mg per kg dose, sir.
That's right. But still, right now the standard dose is 50 milligram per kilo
15,
on 2 days. Yeah.
2 days followed by.
There are trials which are happening, but the standard dose remains that. And
Yes,
what it does is that it delays engraftment by few days. And that we need to be careful about. Okay. So what was the next question, Shashwat?
Sir, skin toxicity, thiotepa, how to prevent?
Yes. So tell me, how do you prevent it?
Sir, I don't know, sir.
Maybe Shashwat can answer that one. Shashwat, it's your question. Maybe you can answer this.
Sir, we do sponge bath every 6 hourly. So it's used with the protocol that we write thiotepa. We every time we write sponge bath every 3 hourly, we change the clothes and the bed linens and we do sponge bath.
So how does that help?
So because thiotepa is excreted through the skin, so the residual toxicity will be less.
Yes, true. So that's the reason why that sponging is done, because thiotepa is excreted in skin and it can be accumulated there to cause a lot of skin toxicity. Any other questions, Shashwat, do you have in your slide set, or Rakesh?
Yes, sir. There is a pertinent question of CSA tacrolimus confusion. Suppose if the patient develops severe mucositis and is not able to take oral tacrolimus, and that is the only formulation that we have available, does this form a indication to change to IV cyclosporine? Or is it one of the indications of in a regimen where you anticipate high mucositis, probably CSA-MTX is probably a better way to go ahead? Just an extrapolation to that particular question.
Yeah. So if there is a high incidence of mucositis, perhaps any drug which can be given IV would be preferred. to tide over the mucositis. However, even with tacrolimus, what happens is that you can also use it sublingually, and that leads to its absorption. However, my own personal opinion is that if it's a haplotransplant or a match related, I would continue to use cyclosporin, because anyways I'm using PTCY for haplo, and even if I use cyclosporin methotrexate for related, that's fine, it's IV. In unrelated, we always use tacrolimus methotrexate, and that can be given sublingually. Some of the oral
Fantastic.
preparations can be given sublingually.
So, do you prefer to use MMF instead of MTX in a TMLI or TBI conditioning? In anticipation of high mucositis and methotrexate worsening the mucositis, and probably you're not able to give day 6 and day 11 doses as relevant.
So, there is only one randomized study comparing cyclosporin methotrexate to cyclosporin MMF, and that did not show that cyclosporin MMF was better. So the standard regimen still remains cyclosporin methotrexate, wherever it is used, especially in sibling transplant.
Yes. Thank you.
Sir, if you are not able to give third dose of methotrexate, then what should be done, sir?
So typically what happens, am I now the examinee, Amol?
No, sir, no, sir, no, sir. I had a doubt, sir. Because somewhere it is given that only 3 doses, and somewhere it is given we have to give 4 doses. So that's why.
I like it. The examinee has turned examiner now. So
No,
typically
sir,
what happens, typically, you can always give half the dose of methotrexate, and there are some regimens which are only using it for 3 doses. The typical standard Seattle regimen was 4 doses, 1, 3, 6, 11. We typically uses those 4 doses, and if we have significant mucositis, we decrease the dose by 50% in day 6 and day 11. Sometimes, rarely, we have omitted later doses, and my own personal feeling is that when you omit it, it increases the risk of GVHD. Now, it increases the risk of GVHD maybe because of 2 reasons. One, because of that significant mucositis. That is why the GVHD incidence has increased, because there's already damage to the gut epithelium. So methotrexate, not giving 1 dose of methotrexate, I'm not sure how much it adds. Second is that methotrexate dose has been omitted, so it may increase the risk of GVHD. Now, whether it's the chicken or the egg, it doesn't, no one can, I don't think anyone can answer that. But wherever possible, one should try to give all the doses planned, whether 3 or 4.
Got it.
Any other questions in the chat box or slides or whatever? Which drug is used prior to stem cell infusion myeloma? That's an easy one, Amol.
Melphalan, sir. 200 mg.
And what dose?
200 mg per meter, sir.
Excellent. Next question. This we discussed. Next question.
Hypertension, renal dysfunction.
Yeah, this also we discussed. Next question.
I think we have answered almost all the questions, sir. I'm just going through the chat box to.
This also we discussed.
Q&A, rather.
Next.
All the questions.
Steroid is a drug of choice. Steroid is a drug of choice.
Few more questions pending, Dr. Shashwat, in your list of questions.
No, sir. It's covered mostly, sir.
So this is steroids.
Yes,
they
sir.
remain the drug of choice. It's always a double-edged sword. It's the best as well as the worst drug.
Worst drug.
Why is it the worst drug?
So cannot queue for long time and cannot make them steroid dependent.
So when you use it for a long time, the complications of steroids cannot be matched by any other drug. They can cause lots of problems.
Sir, ruxolitinib is a drug of choice for steroid refractory GVHD, 10 mg twice a
Yes.
day.
Is the standard is now ruxolitinib. Next. Any further questions, Shashwat? Yeah, what are the common side effects of ruxolitinib?
No, sir.
Yeah, so maybe Shashwat, you can answer this question.
Most commonly, we see cytopenias and viral reactivations and infections.
Yes. So cytopenias are the most common complications of this. Next.
Belmosudil.
Yes.
The coast. No.
Maybe you
Sir,
can
I don't
answer
remember.
this, Shashwat.
It's new drug for management of chronic
The
GVHD,
ROC2
inhibitor. Yeah.
Yeah. And this is a drug which is perhaps a good drug for chronic GVHD, mostly musculoskeletal and skin, but it takes quite a bit of time for it to start acting. Next. Okay, that is also there. I didn't know that was the next question. No. So maybe Shashwat, you can answer this question.
Yes, sir, you already answered. The
Next.
musculoskeletal system followed by GI. So these are
That's
also,
it.
yes.
Any other questions?
I think only one last question remaining in the Q&A box, sir. That is letermovir. If the patient is given letermovir prophylaxis, should the dose be reduced to 250 mg OD? If the patient is on tacrolimus, should we be giving 240 mg BD dose?
So with CNI,
Letermovir
the
with
dose,
tacrolimus.
yes. So with CNI, the dose is usually 240 milligram. It's not 480, but this is possibly a bit more with cyclosporin. But I think for tacrolimus, I'm not completely sure, but I know for sure that with cyclosporin, it is 240 because it increases the level of letermovir.
I think
Any other question?
we have taken all the questions, sir.
Okay, excellent. And we've completed, it's already 4 o'clock. So,
Well on
when
time.
Karan told me that, you are supposed to ask question till 1 hour, I was just wondering how will the examinee as well as examiner last for this 1 hour of grilling?
But I think it was
But I
a
think he
very
has done
fruitful.
reasonably
Yeah.
well. Yeah, he has done reasonably well. So well done, Amol. I think I will to just be taking sir's question one after the other. It takes a lot of, and I think you have done reasonably well.
He has done
Absolutely,
very
sir.
well.
Yes,
Thank you,
sir.
sir.
And we are all the beneficiaries. We learned a lot. Thank you, Karan, for that. Thank you.
Thank you, sir, so much for joining. And I think it revives
Actually, we
very
had
good
a
memories.
case. Sir, we had one case, sir. He was DLBCL. Hello, sir.
Yes.
So, my consultant had taken your advice for that for pulmonary issues were there. That time you recommended LACE regimen and also.
Yes.
That's
Yes,
how
sir.
I.
This was one of the questions that I had. Beam versus lace.
Yes, sir. That's
So it becomes so very difficult to manage beam these days, sir, with the kind of mucosal toxicities and the MDR drugs that are coming up left, right, and center with the I mean, sepsis. So what do you think, sir, for Indian conditioning, Indian conditions, should we go for lace rather than beam?
So
lymphomas.
90% of what we use is always lace, Rakesh. I think we must be having the largest data in the world of lace.
Yeah.
Our default setting is lace. Sometimes we use beam. We use beam when we think that the cardiac function may not be great,
Okay.
because cyclophosphamide causes cardiac dysfunction. So, for that we use beam, otherwise we use lace.
Sir,
Thank you, sir.
I had one doubt regarding this irradiated blood products. So the main aim is to prevent transfusion-associated GVHD.
Yes.
So in the indication, in different guidelines, different thing is given. At one, I found that it is to be given in lymphomas, leukemias, irrespective of the type. But somewhere I'm finding it is to be given in Hodgkin lymphoma only. So what?
So any disease which is significantly immune suppressive, it is safer to use irradiated blood products. So I will give it to most blood diseases where there is significant immune suppression. So that will include the acute leukemias and the lymphomas.
Okay, sir.
Because if you develop transfusion-associated GVHD, it's fatal in a large proportion of patients. I wouldn't
Yes,
really
sir.
want to do that. For solid tumors, I would not give irradiated blood products.
Okay, sir.
For CML, perhaps I will not give it, But
Okay.
for most of the immune suppressive blood disorders, I would give it.
Okay. Got it. Thank you.
I think that's it for today, right?
Yes, sir,
Karan?
that's
Yes.
it for today, sir. Thank you so much. I think it was a good discussion, and I was just saying that it reminds me of my time with you and the BMT posting, just reminiscent of those lectures that we had with you. So thank you so much, sir, for taking out time on a Sunday afternoon and teaching the residents. They were all looking forward to this lecture. And thank you, Rakesh, sir. Thank you, Saswat, sir. And thank you, Stalin, sir. And thank you, Amol, for doing this. It was a lovely session. I must introduce you to our next lecture, which is drugs in pediatric malignancies. And we have Dr. Sameer Bakshi, who will be our examiner. And our moderator is Dr. Raghu KS from TMC Kolkata. And our speaker is Dr. Nand Kumar from RCC Trivandrum. So I think we can all join in next Sunday for this session. And with that, I will thank you all. We'll end the session now.
I want to say something. Thank you, Dr. Karan. Actually, Dr. Karan only promoted me to take part as an examinee and take part transplant. So due to which I was able to read, and then I found out that it's a very big topic, transplant, and there are a lot of things. Many of our, like in medical oncology, we don't get that much exposure to the transplant part. So thank you, Dr. Karan, that you asked me to take this topic. I'm thankful.
Most welcome, Amol.
I think medical oncologists should take interest in hemato-oncology and transplants. I think that is something that is not being done as much, probably because something related to training level exposure. But I think this is this session is definitely a bridge session. As Amol found out, rest of you must have found out, and probably I think you all should take up transplant, take a cue out of Dr. Navin sir's vast interest and expertise and experience, and be benefited from that.
Now, great
And-
session. I really
Yes.
enjoyed. I was wondering what do we need to do in this, because I had not
As I said, sir,
experienced this.
once discussion starts, everything else will start falling into place.
I think, sir, this is
Yeah.
something similar to what you do on your Sunday afternoons, but it's just what was the chemotherapy part which you discussed. So rather than just TMH residents enjoying that, almost most of the YMO have this now. So thank you so much, sir. Thank you so much.
Excellent. Bye. Thank you.
Bye, sir.
Thank you, sir.
Bye.
Thank you,
Bye,
sir.
bye, bye.
Bye.
You. we'll
Right.
leave the session now. Thank you.